welcome back to another episode of the Neuro Knowledge Podcast. This week's episode will focus on Parkinson's disease. I'm your host, Scott, as always, and just before we jump into this week's episode, I'd like to remind everyone that the podcast is available on iTunes, Google Play, Spotify, and on our Facebook page. And with that, let's jump into today's episode, which focuses on Parkinson's disease. Parkinson's disease is a progressive neurodegenerative condition which is the result of a buildup of abnormal proteins in the brain. This buildup of proteins eventually leads to a reduced level of a neurotransmitter called dopamine. It is important to separate a couple terms before we jump into Parkinson's disease in detail. These terms are Parkinsonism and Parkinson's disease. Parkinsonism is the clinical picture of slow movement, rigidity, tremor, and balance issues. Now, this can be the result of multiple different things, including side effects of multiple medications, particularly antipsychotics and anti-nausea medications if they're used at high doses. However, when the symptoms of Parkinsonism are present without such confounding factors and there's a suspicion that the symptoms are related to a reduced level of dopamine in the brain, Parkinson's disease is diagnosed. Parkinson's is fortunately a very rare disease affecting about 0.3% of the population, which is anywhere from 7 to 8 million people worldwide. The disease does become more prevalent as we age, however. For those aged 40 to 49, there's approximately 40 cases of Parkinson's disease for 100,000 people. For those over age 80, this number drastically increases to approximately 1,900 to 2,000 cases per 100,000 people. In Parkinson's, a protein called alpha-synuclein forms inclusions called Lewy bodies in the brain. This is a very similar process to the beta amyloid and tau proteins that we discussed in Alzheimer's. Lewy bodies accumulate in different areas of the brain, but in particular the brainstem, the transition point between the spinal cord and the brain, which houses a variety of nerves and nerve pathways, really a high-priced real estate area in that regard. The proteins also build up in the basal ganglia, which are different areas throughout the brain. In the brainstem, the most severely affected area is something called the substantia nigra. This area houses a large number of neurons which produce and transmit the neurotransmitter dopamine. As Lewy bodies accumulate in the substantia nigra, the neurons which produce dopamine are slowly lost, and this results in less and less dopamine being produced over time. Initially, someone may not have many symptoms of Parkinsonism. However, as the neurons are lost and the dopamine level is further reduced, symptoms can begin to show. The basal ganglia are a number of different areas, including the caudate, the putamen, globus pallidus, thalamus, subthalamic nucleus, and the substantia nigra. They all work together to help in coordinating movements, both promoting movement and at other times inhibiting movement via different pathways. Lewy bodies build up in these areas as well, along with other surrounding areas of brain tissue to a lesser degree. The decreasing amount of dopamine produced from the substantia nigra over time results in an increase in activity through a basal ganglia pathway, which inhibits or reduces movement, and a decrease in pathways which promote movement. This eventually leads to the clinical features of Parkinsonism, which most people are familiar with. The classical features of Parkinson's disease include bradykinesia, which means slow movement, rigidity of the limbs, which usually affects one side more than the other, and a tremor, which is quite noticeable at rest. Another feature of the disease is postural instability or balance difficulty. However, this typically shows up later in the disease course. The tremor seen in Parkinson's disease occurs at rest and actually tends to improve with activities such as eating or writing. With it being present at rest, people afflicted with Parkinson's at times will try to minimize it or hide the tremor by placing their hand, which is unaffected, over the hand with the tremor, or keeping the hand affected with the tremor between their legs or under their arm, etc., trying to minimize the degree to which the tremor can be noticed by others. It tends to increase when someone is distracted, and so it can be more noticeable when they are talking or if they're walking and focusing on something else. There are a number of other symptoms which can be seen either preceding a diagnosis of Parkinson's disease or during the disease course. A decreased sense of smell is often reported, quite interestingly, and this tends to predate the diagnosis by decades. Also, a tendency towards constipation tends to predate the diagnosis as well. Changes in handwriting can also be seen, and most notably, it's much smaller, kind of difficult to make out handwriting. A softer voice can sometimes be seen along with what is called a masked facies. This largely means a decreased rate of blinking and at times a less emotionally expressive face than one had in the past. Interestingly, depression is also fairly commonly seen either before a diagnosis or during the disease course. And finally, The walking or gait of a person with Parkinson's tend to have smaller and at times shuffling steps, along with a bit of a stooped posture. This is largely the result of the bradykinesia and rigidity features of Parkinson's disease, rather. In terms of the risk factors for developing Parkinson's, again, a family history of the disease is an important risk factor, and there are a variety of different genes which can increase a person's risk from this standpoint. As you probably noticed, there seems to be a recurring theme there, or recurring trend in many of the conditions we discussed, that a family history of the condition is a fairly common risk factor for developing the disease later on. Interestingly, there appears to be increasing evidence that exposure to pesticides may increase one's risk for developing Parkinson's disease over time. Additionally, I think much of the public is also aware of brain trauma and really repeated brain trauma increasing one's risk of developing Parkinson's disease, largely due to Muhammad Ali and his affliction with the disease, which has been pretty publicized over the years. Several studies have looked at different degrees of traumatic brain injury, from mild TBI, which is essentially a concussion, to more severe brain injuries, where someone may be in a comatose state or have bleeding on the brain. There appears to be an increasing risk of developing Parkinson's disease with an increased severity of brain injury, meaning those more severe brain injuries, where someone has a prolonged loss of consciousness or may have bleeding in the brain, can lead to an increased risk of developing Parkinson's disease compared to a mild or traumatic brain injury. There also appears to be a greater increased risk with repeated injury, and so those individuals, such as a boxer like Muhammad Ali, who suffered a number of traumatic brain injuries over the years, would be at higher risk compared to someone who may have had just one concussion, say. Now, it is, I think, very important to point out that a history of head trauma, while it does increase one's risk to develop Parkinson's disease compared to somebody without head trauma, it has not been shown to directly cause Parkinson's disease. And this is a very important point to spell out amongst all the conditions we discussed, that while certain risk factors will increase one's chance of perhaps developing the disease, they don't directly cause the disease. In addition, I think we can discuss several protective factors which research has shown to, or at least seem to, reduce a person's risk of developing Parkinson's disease. Interestingly, those who smoke or did smoke seem to have a reduced rate of developing Parkinson's compared to those who've never smoked. Now, obviously, I'll say that the overwhelming negatives of smoking on numerous other areas of health would definitely outweigh this reduced risk of developing Parkinson's disease. However, this has been shown in studies. Additionally, increased caffeine intake and regular moderate to vigorous activity have also been shown to be protective factors. Now, when we discuss Parkinson's disease and we discuss the diagnosis of the disease, it's really strongly based off a clinical history and a neurologic exam. The clinical history, which is usually obtained from a patient and their family, typically shows some fairly common recurring themes. Typically, a prominent rest tremor and or walking difficulties are what tend to bring people to the doctor in most cases. If a person comes into the doctor's office and they have a fairly typical history, as well as physical exam findings with the classical features of Parkinson's, including a rest tremor, rigidity affecting one side more than the other, bradykinesia, which is that slow movement we discussed, then there's really fairly limited additional testing which is typically performed. Head imaging with a head CT or MRI is actually pretty rarely obtained, especially with a straightforward story and physical exam. Obviously, one should review medications in order to see if any of them could be causing Parkinsonism or the symptoms that the patient is complaining of. Now, if someone does present with features of Parkinsonism with additional atypical features such as prominent falling early on in the disease course, hallucinations, difficulties with the autonomic nervous system, which include marked blood pressure changes when standing up, severe constipation, etc., or cognitive difficulties, this may prompt a more extensive workup. With these features, doctors would be concerned about Parkinsonian variants, and these include conditions such as progressive supranuclear palsy, or PSP, Lewy body dementia, multiple system atrophy, or MSA, as well as cortical basal degeneration, or CBD. These conditions will be the focus of a future podcast once we've discussed Parkinson's disease in detail. Once a diagnosis of Parkinson's disease is suspected, a trial of a dopamine-based medication is typically started. The most common medication that is initially tried is a medication called Sinemet. This consists of levodopa, which is a precursor to dopamine, which will eventually be used by the brain, along with carbidopa. Carbidopa is an inhibitor of enzymes in the bloodstream which tend to break down levodopa before it can get to the brain. Because Sinemet is an oral medication, it must first be absorbed from the gut and then travel through the bloodstream to get to the brain. And so carbidopa helps prevent the breakdown of levodopa during this time. This hopefully allows for the maximum amount of levodopa to make it to the brain where it will be useful. Once there, levodopa gets converted into dopamine and helps supplement the depleted levels of that neurotransmitter, which is seen in the Parkinson's patients. The medication is usually started at a fairly low dose and titrated upwards, but once a sufficient dose of approximately 3 tablets 3 times a day is reached, a repeat physical exam is often performed. If there has been substantial improvement in the Parkinsonian features from the prior exam, a diagnosis of Parkinson's disease is essentially confirmed. It's important to point out that a lot of those atypical Parkinsonian variants we previously discussed typically don't have much of a response to levodopa. It's important to point out that the absorption of the medication can be affected by diet and meals. The medication should be taken approximately an hour before or 2 hours after a meal and should not be taken with dairy, protein, or multivitamins, which are rich in minerals such as iron. These substances can impair the absorption of the levodopa, which can prevent it from reaching the brain. The medication is not without side effects, however, and some common difficulties when starting the medication include nausea, confusion, and changes in behavior, hallucinations, and orthostatic hypotension, which is essentially an abnormal drop in blood pressure when someone stands up. This can lead to lightheadedness and syncope if severe. If these side effects are experienced, then a reduction in the dose of the medication is typically needed. This should be discussed with the prescribing doctor prior to doing so. Because of the chronic progressive nature of the disease, over years of treatment with levodopa, several issues can arise. The first issue is a phenomenon called wearing off. This means that the carbidopa-levodopa is taken, the benefits and relief of Parkinsonian features occurs for a shorter and shorter period of time than when treatment initially began. This means that someone may have the return of Parkinsonian features before their next dose of medication. Ultimately, this can require more frequent doses throughout the day, from that 3 times a day we initially discussed to 4 and 5 and upwards. And so this can be something that is fairly commonly seen over time. I think here it's important to identify a misconception regarding Parkinson's disease and levodopa therapy. Typically when people begin levodopa therapy, they have a fairly marked response in a lot of their symptoms, including the tremor and slowness of movement, etc. And so patients as well as families can think, well, because of this response, the disease is under control and will remain under control for some time, and that it won't get worse. While this initial response is great and people can have a lot of benefit in that initial time period, because of the neurodegenerative and progressive neurodegenerative processes at play, meaning in Parkinson's disease that alpha-synuclein protein is continuing to build up in the basal ganglia and the dopamine levels produced by the brain itself are continuing to decline, a person will require more and more dopamine over time. This combined with the metabolism of levodopa by the body over time can also lead to this phenomenon of wearing off. This can lead to what are called on and off times. After taking the medication and it begins to have an effect, a person is said to be in their on time or on state. During this time, someone enjoys improved mobility and reduced Parkinsonism or Parkinsonian features. As the dose of the medication wears off, however, Parkinson features return, which includes reduced mobility, slowness in movement, tremor, etc. Someone is then said to be in their off time or off state. More doses of levodopa are added throughout the day, like we discussed previously, to maximize the time in the on state and minimize the time in the off state. This results in a greater total dose of levodopa and dopamine delivered to the brain on a daily basis. This increasing total amount of levodopa throughout the day can lead to a side effect called dyskinesias. These are abnormal, uncontrolled movements which can have a wriggling, kind of writhing, and at times fidgeting appearance. I think if anyone has seen Michael J. Fox during an interview, at times he can have the appearance of dyskinesias during those while he's in the on state. They tend to occur at the peak of a levodopa doses effect, meaning they typically occur when someone is in their on state or in their on time. I think a misconception we can address here is that surrounding dyskinesias. Often these movements tend to be much more concerning and unsettling to a patient's family members than to themselves. Given that they tend to occur during the on state or on time, a person's Parkinsonian features are often the most relieved at this time, and so they are free to move and have freedom to do their activities. Obviously, dyskinesias are not ideal, but at least in my experience, most patients find that having their ability to move restricted as the most distressing part of Parkinson's disease, as opposed to perhaps some mild to moderate dyskinesias. Each person is different, however, and particularly severe dyskinesias can be an issue which requires medication dose changes and specifically dose reductions. There is also a medication called amantadine, which is aimed at reducing the severity of dyskinesias. In severe cases, however, this medication may not be effective enough, and so a dose reduction again may be needed. An additional point to point out regarding levodopa and carbidopa-based medications is the wide range of controlled release formulations that are available. These medications have a slower release of levodopa and carbidopa over time, which is hopefully of some benefit in those suffering from wearing off, and that it can hopefully bridge the gap between their dose times. Now, while carbidopa-levodopa-based medications are typically the mainstays of Parkinson's treatments, there are additional medications which can be a benefit which don't rely on levodopa. There are medications which directly stimulate dopamine receptors in the brain, and these medications are such things as pramipexole, or Mirapex being the brand name, or ropinirole, which is Requip as the brand name. They are used more consistently actually in restless leg syndrome. However, they can be used in isolation or in addition to levodopa in Parkinson's as well. I would say that the main limiting factor regarding the use of these medications are their side effects, and these include things such as nausea, dizziness, excessive somnolence, which is frequently falling asleep, and feeling of malaise, amongst other things. A rare but very important side effect to discuss before the medication is started, and is often pointed out to patients, is the potential for impulsive and compulsive behaviors to develop. These behaviors include such things as excessive gambling, shopping, or sexual addiction. These can be quite severe and should be monitored for by the family members close to someone taking the medication. Additional medications include a medication called entacapone, or Comtan is the brand name. This is a medication that's aimed at preventing the breakdown of levodopa, similar to carbidopa, but it inhibits a different enzyme which breaks down levodopa. There are other medications which have been used historically, however, their use has largely fallen out of favor more recently with improved medication options, specifically improved levodopa-based formulations, such as the controlled release formulations. Finally, I think we can briefly touch on the topic of deep brain stimulation, or DBS therapy, for Parkinson's disease. Now, deep brain stimulation therapy is a brain surgery, and obviously given that, it should be very thoroughly discussed with one's neurologist, other medical providers, and their family before such a therapy is undertaken. As we discussed previously, Parkinson's disease is largely a disease that affects the basal ganglia areas of the brain. With deep brain stimulation, or DBS, the specific area within the basal ganglia leading to the main limiting symptom is targeted. Whether the symptom is tremor or bradykinesia, rigidity, requires targeting of a different sub-area of the basal ganglia. Extensive imaging of the brain is required in preparation for a brain surgery where the DBS electrodes are inserted into the specific targeted area of the basal ganglia. There is then a small battery pack and receiver that's implanted on the chest wall, which is slightly smaller than a pacemaker. This is connected to the electrodes via a very small wire, and the receiver within the pack on the chest wall allows the electrodes to be programmed in different ways. These programming details can be modified over time depending on a person's symptoms and the control of those symptoms which is needed. Typically, a neurologist who is trained specifically in movement disorders is capable of adjusting the deep brain stimulator at follow-up appointments in order to adjust for different symptoms or perhaps even side effects that a person is having. The DBS therapy can be quite beneficial, particularly in the area of tremor, where it is used outside of Parkinson's disease as well for people with essential tremor. There are certain features of Parkinson's, however, which are less effectively relieved via deep brain stimulation, and so the therapy is typically not pursued if those are the main limiting features of the disease. I think we can also touch on several of the non-motor or non-movement related symptoms of Parkinson's disease as well. Because of the buildup of alpha-synuclein and Lewy bodies throughout the brain, not just the basal ganglia, the potential for dementia is present. This is particularly true in people who have had a long course of Parkinson's disease over many years or even decades. This should be screened for, especially if there is a concern for cognitive difficulties. The dementia can either be the result of Parkinson's disease itself, or another form of dementia could be working alongside Parkinson's disease. Additionally, in Parkinson's patients, depression is a fairly common symptom that should also be discussed and really watched for. Obviously, there's a multitude of medications and different therapies available for those suffering from depression, and so this is a symptom that is quite prevalent in Parkinson's disease patients, and so both themselves, their physicians, and their families should be aware to kind of keep an eye out for this. And finally, I think we can talk about constipation as well. Typically, patients with Parkinson's disease suffer from some form of constipation. However, this can be quite severe and would require treatment with either stool softeners or laxatives or things that help with motility or some combination of all of those. All right, I think that brings us to the end of another episode of the podcast. Thank you again for listening. Today we discussed Parkinson's disease and addressed some misconceptions regarding the diagnosis. The misconceptions we addressed were the initial response to levodopa therapy, but the unfortunate progressive nature of Parkinson's disease, meaning that more levodopa will be required over time. We also discussed misconceptions regarding dyskinesias. For additional information on Parkinson's disease and deep brain stimulator therapy or DBS therapy, please look at the links in the episode description below. Also, before you go, if you're enjoying the podcast, please don't be hesitant about rating us on whichever outlet you do listen to us on. Your feedback is very beneficial in terms of making adjustments to the podcast and improvements in order to increase our listenership and education that we're able to provide. And with that, we hope to see you back in a couple of weeks when our topic will focus on multiple sclerosis. It should be a very informative and interesting discussion. Thank you again for listening. Take care. The Neuroknowledge podcast is meant as an informational resource for patients and their families. It is not meant to diagnose or treat any medical condition. It is not meant as a replacement for medical evaluation. The views expressed in the podcast are solely those of the speakers and do not necessarily reflect those of Mayo Clinic or its subsidiaries.